The title of today's commentary is A Testing Time for Aging, Geronticide or Necropolitics. With the COVID-19 proliferation ticking on a dreadful speed, humanity is in the throes of an unprecedented breakdown. Severe acute respiratory syndrome coronavirus 2, we call it SARS-CoV-2, seems to have the armory to legitimate the Darwinian dictum, survival of the fittest. Even the world's mega towns and mega cities of affluence, abundance have gone bust. The world's developed as well as the fast-growing economies and societies have fallen prey to the contagion 2020, perhaps more quickly than the case with the poor and backward economies and societies. It might be a matter of time when the pandemic proliferates with a high speed, both vertically and horizontally in the global south countries too. That's why we say that the poor and backward countries of the global south cannot indulge in complacency. But of course, there are lessons to be learned and unlearned from the badly affected countries of the global north. The United Nations Development Programme has already warned that the growing COVID-19 crisis has threatened to disproportionately hit developing countries, not only as a health crisis in the short term, but as a devastating social and economic crisis over the months and years to come. It further said that the income losses would exceed $220 billion in developing countries, even as 55% of the world's population have no access to social protection. These losses will be carried across societies with grave implications for education, human rights, and the most critical cases, basic food security and nutrition. The UNDP has also alerted that in these countries, under-resourced hospitals and weak health systems are likely to be under severe pressure. This may be aggravated further by a spurt in cases, in as much as 3/4 of the people lack access to water, soap, sanitation, etc., etc. Needless to say, the worst casualty of the current pandemic is human security. The very survival of humanity is now contingent upon how each and everyone in this bio landscape is recasting security. SARS coronavirus has transformed itself into a structure of unpredictable behavior. In less than 6 months, with the medical research institutions and global health infrastructure groping in the dark. They are literally in the dark with insufficient data on diffusion intensity and containment strategies. The prescribed strategies are only social tactics in the absence of effective medical management, such as social distancing, self-isolation, lockdown, etc., etc. The aim of this social tactic is to let the pandemic virus peter out spontaneously, leaving no scope for further proliferation. Then what is a guarantee that the entire species will vanish after 2 weeks or 3 weeks, even as the populace in hotspots take refuge in cartilage, to use a Foucauldian term? It is for the medical researchers to ponder over this question. Admittedly, the entire biomedical communities across the world have been working round the clock in search of a solution. However, there is no effective remedy yet to fix a virus. At best, a vaccine might be developed sooner or later to infuse confidence that the pathogen can be prevented from within. But the question at this critical juncture is, are we heading towards a geronticide or a necropolitics? Statistics of death rates in the cities of the global north baffle many. Unlike the influenza pandemic of 1918-19, COVID-19 tends to affect people in the aging populace, particularly for those people who are vulnerable with the respiratory, cardiac, diabetic, or any other vital organ complaints. That means each affected country should have tens of thousands of ventilators and emergency medical facilities to take care of them. This is important because the data of death rates among the aging population show a high percentage of fatality from the upper age group. There were reports from some countries that a section of hospitals in the global north, particularly in Europe and United States, they used to discourage aging people with the COVID-19 symptoms approaching for medical care as if they were to put up with the inevitable fate of death. More than 95% of the deaths reported from COVID-19 infection in Europe were people in the age category of above 60. This has been the case in the United States and other badly affected countries in Europe. Notwithstanding the greater risk of critical illness and death from the coronavirus, discriminatory attitudes and actions endanger older people's rights. A British newspaper opinion report about the economic implications of the coronavirus showed that the death of older people could actually be beneficial by culling elderly dependence. Ukraine's former health minister in an interview said that people above 65 were already corpses and the government should focus its COVID-19 efforts on people who are still alive. Another interesting case could be a Texas lieutenant governor was reported to have suggested that grandparents should be willing to risk death from COVID-19 in order to prop up the US economy. Similarly, physicians at the Italian College of Anesthesia, Analgesia, Resuscitation and Intensive Care, they warn that it may become necessary to establish an age limit for access to intensive care. Another physician in northern Italy told the New England Journal of Medicine, "There is no way to find an exception. We have to decide who must die and whom we shall keep alive." The approach is obviously more utilitarian in times of catastrophe. When systems are overrun during wars and natural disasters, doctors must decide how to maximize resources for the greatest social good. In the United States too, some doctors were apparently unwilling to give ventilators to people over a certain age. US ethicists, they believe that one should save the lives of those who can do the greatest good. Of course, there is also a consensus that shifted from maximizing lives saved to maximizing life years. Saving one child may outweigh the good of saving two elderly adults. According to the cold arithmetic of life expectancy. Two 88-year-old patients in New York City's Elmhurst Hospital Center, they were told that neither would get a ventilator because the hospital has not had success with people of advanced age. So age-based priority is now part of official guidelines in some states for dealing with the COVID-19. It was only recently that Washington Post reported that some states recommended to deny access to ventilators for older people, with access barred to those ranging in age from 65 to 85. This is in the context of epidemiological estimates that as many as 40–60% of this country's population of 327 million could eventually become infected. According to Lee Doughty Bidison, who is working at the Department of Pulmonary and Healthcare at Johns Hopkins Medicine, the idea is to give priority to those most likely to live a longer life after they got through the current epidemic. Rousseau from Duke noted that part of planning for larger pandemic outbreak in the US should involve ensuring comfort to dying people who will go without advanced intensive care. However, the United States used to have a very strong ethical guidelines module on this question. For example, as part of emergency preparedness efforts, the Department of Health, together with the New York State Task Force on Life and the Law, they had released the ventilator allocation guidelines way back in 2015, which had actually set forth an ethical, clinical, and legal framework to support healthcare providers and the general public in the context of a severe influenza pandemic. The first guidelines, which appeared in 2017, had dealt with the allocation of ventilators for adults and were among the first of their kind in the United States. The 2015 version was also a landmark in that it included two new detailed clinical ventilator allocation protocols, one for pediatric patients and another for neonates. The COVID-19 actually calls for a thorough revision of the ethical guidelines put in place in 2015. According to two scholars working with healthcare, they said that the public health officials should promote transparency and use their specialized knowledge and skills to ensure that the public trust is maintained in a changing situation. Healthcare providers will look to a well-organized response that is grounded in science and ethics as the US response to COVID-19. Coming back to the other questions, it is in this context that we are grappling with a world of hard choices of life and death or life or death. This is exactly a question raised by a Cameroonian philosopher and political theorist, Chile Mbes, on the concept of necropolitics. Mbes' concept of necropolitics was already very popular with social sciences scholars and institutions since 2003. It had gained a lot of attention at that point of time. Membe had advanced the notion of necropolitics way back in 2003 with a commentary in public culture. And it was in 2019 that Chile Mempe came out with his book, Necropolitics. He had actually drawn insights from Foucault's concept of biopolitics. And Membe tried to elucidate necropolitics by exploring the genealogy of the current world, a scenario beset by growing inequality, militarization, enmity, and terror, as well as by a revival of racist, fascist, and nationalist credo, which went on promoting exclusion and killing. Foucault had actually observed how biopolitics, power over life, can become a deadly form of power. It is not only a calculated management of life, but also a power to expose a whole population to death. Membe, he had argued in his earlier essay that we have to go beyond the concept of biopower elucidated by Foucault. And he went further and said that the ultimate expression of sovereignty resides to a large degree in the power and the capacity to dictate who may live and who must die. Hence, to kill or to allow to live constitute the limits of sovereignty, its fundamental attributes. To exercise sovereignty is to exercise control over mortality and to define life as the deployment and manifestation of power. Christopher Lee recently argued that the COVID-19 pandemic is a classical test of Membe's contentions on necropolitics. According to Lee, though this established set of politics has fundamentally shaped the infrastructural capacities of states to respond to the crisis, namely with the neoliberal northern democracies such as Britain and the United States facing a distinct challenge in responding from years of austerity and the privatization of medical care, neither should the opportunity be lost to think differently about what is at stake. COVID-19 isn't simply a medical or epidemiological crisis, it is a crisis of sovereignty, according to Lee. And Lee further observed that the current pace of intervention amounts to a return to the most basic techniques of territorial control and state power, a politics of border restriction, community management, evening curfews, business closure, public dispersal, and empty streets. Citizens are further asked to self-discipline in a Foucauldian fashion through social distancing. The scale, speed, and global extent of these sovereign measures appear unprecedented. Lee notes that these measures constitute a reactionary version of necropolitics concerned with the management of life and death. To reduce disease proliferation, mortality numbers, and the rate of infection more generally. The Contagion 2020 has clearly showed a long-term failure among states to sustain public life, to sustain life, health, through their commitment to neoliberal agenda, to end state welfare in favor of privatization. Christopher Lee noted that the US and British governments were particularly abominable in governing on the basis of provisional schemes of affordable death through privatization and austerity measures, respectively. So, going beyond Membe's elucidation of necropolitics along the scenario of war machines, suicide bombing, etc., Lee writes that who gets to live and who gets to die is dependent on the goodwill, ability, and expertise of medical workers and others directly engaged with the situation. So the power to dictate who may live has been outsourced and increasingly privatized, available only to those who can afford it. Only who can afford it. So Lee's observation of necropolitics has direct implications for the fate of the older people across the world today. I would say that this a possible Geronticide is in the offing, and we may name it as a necropolitics of a different sort today. There are now increasing concerns expressed by a large number of human rights groups and activists across the world that older people who find themselves suddenly alone without control over their social milieu, they are in specific risk for a variety of severe, life-threatening physical and mental health conditions. They argue that restrictions on their freedom of movement should be proportionate and not based entirely on age. Governments may have to address the risk of social isolation while taking care of health needs during social distancing. Studies already testified that older people often end up in care homes because of government's failure to render adequate social services for people to live independently in their community. Policies that have put millions at added risk of contracting the virus because of their institutionalization. So governments should ensure continuity of community-based services so that people do not end up in institutions in the absence of other options. So a report suggested that the UK government, rather than improving social care provisions for older people at this time, has instead put on hold basic necessities for social care and service arrangements. Many community workers and physicians argue that age should not be a prime criterion for denying treatment. Public policy should guide medical personnel in decisions about allocating resources and monitor for discrimination in accessing medical services for all high-risk groups, including older people. They argue that governments should also recognize and respond to intersecting types of discrimination, particularly for communities like transgenders and so on and so forth. Human Rights Watch has already reminded that thousands of older people who live in refugee and displaced people's camps, where they face health risks from crowd conditions and limited access to health and hygiene supplies, they should be taken care of. They must also ensure that older refugees and displaced older people, they get health care, including access to national health systems and hospitals, regardless of a legal status. According to Bethany Brown, a researcher working on older people's rights at the Human Rights Watch, governments should not respond to threats to older people's health and threats to their rights. Governments should not respond to threats to older people's health with the threats to their lives. We are all at risk if government responses to this endemic or pandemic reinforce ageist attitudes and ignore older people's equal rights. He underlined that older people are disproportionately affected by COVID-19, but they face risks to their rights as well if governments do not take their specific experiences into account and do not actively combat age discrimination. HelpAge expert Prakash Tyagi, he noted, we are already seeing a lot of discrimination and stigma building up against older people with certain myths, doubts and biases. He emphasized the importance of empathy and empowering older persons in the pandemic response to avoid unnecessary suffering from lack of food, health care and poverty. According to him, there are 650 million older persons living in the Asia-Pacific region alone, where many low and middle income countries are struggling to meet both the health and economic needs of vulnerable groups, including older persons living with disabilities, women and children. Traditional ways of working at community may not be possible anymore, and this would be impacting severely on care for older persons, especially those living alone, dependent on home care, and those living in nursing homes. The pandemic, COVID-19, has now clearly set a deadline for a neoliberal austerity package. If the global north countries are kissing the dust, the scenario could be much more calamitous for the global south if they don't learn any lessons from the others. In as much as the austerity rage is evidently dangerous for the world poor, marginalized and excluded, particularly in the global south, a return to the minimum state order in the post-COVID-19 scenario would be self-defeating, if not suicidal. According to the United Nations, by 2030, older persons are projected to outnumber children under age 10, 1.41 billion versus 1.35 billion. In 2050, Projections indicate that there will be more older persons aged 60 or even other adolescents and youth at ages 10 to 24, 2.1 billion versus 2 billion. Globally, the number of persons aged 80 years or over is expected to grow more than threefold between 2017 and 2015, growing from 137 million to 425 million. More importantly, two-thirds of the world's older persons live in the global south countries, where their numbers are rising faster than in the global north countries. So the emerging scenario certainly calls for both the state and international institutions have mutually constitutive roles and responsibilities.